वो मशीन बंद हो गया। नाही ना, होणार थोडा वेळ आता. 9 आवर. तुझे शेंगदाणा क्यों लाया सर उसको, शेंगदाणा नहीं चाहिए लाना. आता होईल एक 10 मिनिटात. तोपर्यंत मी रिवाइज करतो मी काय काय वाचलंय. काय करतो करतो काय तू. गेले ना रे तुझे SRH ह्याच्यात 8. थंड काय कर माहिती का सर आप
ब्रिजेश गया हाँ बटन क्या है। तो कल सुबह में अर्जुन को रेफरेंस कर दो। WBC काउंट कितना है? WBC काउंट कितना है? WBC उसका WBC काउंट कितना है देख केम से आवे हमरा ठीक है। मस्त लग रहा है। कल तो काफी ठीक लग रहे थे, आज थोड़ा सो रहे थे, बट फिर भी एकदम ऐसा नहीं कि 24 घंटा सो रहे हैं। अभी मैं तेरे बॉस के साथ में कल सुबह में सबके साथ बात करके सब रिपोर्ट देख के मैं फोन करता हूँ। तो बोल ना कि सर ने बोला है कल सुबह में आके फिर से सबके साथ में बात के मैं 1 बजे के आजू बाजू में उनको फोन करूंगा। ठीक है, अभी नहीं लगा, अभी उनको फोन करके मैं बोल देता हूँ सर फोन करेंगे। हाँ, सबके साथ बात करके। ठीक है सर। ओके सब रिपोर्ट आए हैं। तो न्यूरोलॉजिस्ट का रिपोर्ट, अर्जुन शाह का रिपोर्ट, उनका रिपोर्ट सबका मिक्स करके मैं फिर उनको बात करूंगा। ठीक है सर। ओके ओके सर। सर स्वेलिंग क्या है हाथ पे पैर पे भी थोड़ा? हाँ जरा डाइट दे देना। ठीक है।
Good evening, Pankaj sir.
Good evening, Hiren.
I think Gaurang sir is also joined.
मैं थोड़ी देर वीडियो ऑफ रखता
Hi,
हूँ.
Hiren,
Yes, sir,
I have
yes, sir.
joined, but we
Yes,
can
sir, yes,
start
sir. Yes, sir.
another 5 minutes.
Yes, sir.
Another 5 minutes and we can start.
Yes, sir, yes.
So, Hiren, I'll join back in 5
Yes, sir.
minutes.
Yes,
I
sir,
was
yes.
continuously on Zoom meetings. Let me have a rapid bite
Ji,
and
ji.
we'll continue.
Ji.
Bye.
So who's presenting today, Pushkar?
Yes. Good evening, sir.
Good evening. And Aditya?
Yeah, good evening, sir. Yes.
Good evening.
Good evening, sir.
Yeah, good evening. Good evening.
And Rahul.
Rahul. Okay.
Yes.
Yeah, good, good.
Good evening, sir.
We are happy that you are proactively participating, all of you. It's a great learning platform, right from the history to the final diagnosis. Last week also we had good cases.
Yes, sir.
Because adrenal mass was good.
Good evening, sir.
Yes.
Good evening.
Who is answering today?
Sir Rahul,
I'm
Pushkar and
answering, sir,
Aditya.
Dr. Santosh Kumar, sir, from Guntur. NRI Medical.
My audio is on.
To start, sir. I think we should start now.
Yes, sir.
Yeah.
Okay,
Vijay,
sir. Yes,
we
sir.
can start.
So, 68-year-old male patient with a complaint of difficulty in passing urine since 2 months.
Okay, Aditya, Santosh, and who else is answering?
Pushkar, sir.
Rahul.
Rahul. Okay. Please elaborate history fast so that we can. Yeah, Rahul, you can start.
Sir, I will like to ask about the onset, progression, and duration of the difficulty in passing urine. Whether it was started acutely or it is increasing day by day, and whether it is associated with any dysuria, any difficulty, sir, any sir, hematuria, any history of sir, lithuria associated with it, or sir, daytime frequency and nighttime frequency. Also, I would like to know about the patient's maturation history, as well as sir, whether it is associated with hesitancy, intermittency, or any associated factor like fever, chills. I would like to know about the history, sir.
So Rahul, very good. I would like to make a comment. Okay.
Yes.
See, you asked us so many questions, but what we want to elaborate here is any case, whether it is hematuria, low urinary tract symptoms, there has to be some set of format in your mind. If you go by that format, then you will, just walk through very comfortably, right? So
Yes.
you started with the onset and all those things, that is fine. Then you went to dysuria, hematuria, lithuria. Then you came to frequency, urgency. Then you went to hesitancy. Now, what is the most important symptom when a patient comes with enlarged prostate? What is the most important symptom?
Sir,
Nocturia.
sir,
Very classically, he tells, right,
classically,
that I go to the washroom and I'm not,
hesitancy,
very good, very good,
hesitancy is
very good,
main
very good.
symptom, sir,
So,
which is
so
avoiding type of symptom.
correct.
So,
So you have to go in a systematic order, beta, whether it is IPSS or AUS score, whatever you would like to use, you
yes,
evaluate
sir.
according to that. So there is a fixed set of symptoms in your mind. You have
Yes,
to
sir.
run the patient through that symptoms. Then you go to
Yes,
negative history, na? Whether there was
yes,
hematuria,
sir.
lithuria, pyuria, fever, chills. So if there is some format in your mind, you will go through that very classically. Same way with any patient with hematuria, there has to be a format. Okay, what will you follow? Okay, so this is just
Yes,
an
sir.
example. So we want you to run through these cases. So now next time when there is a case of prostate, fatapat, you want to run through the IPSS score,
Yes,
then the negative history, then the other
yes,
symptoms, constitutional symptoms, fever, chills, blah, blah, blah. Okay,
yes,
so go in
yes,
that
sir.
order. Very good. Chalo.
Yes, sir.
बता दीजिए ब्रिजेश भाई, उनको आगे बता दीजिए.
So the patient was relatively asymptomatic before 2 months back and started difficult in passing urine with a poor flow, increased frequency every 3 hourly, with hesitancy, urgency, and sense of incomplete voiding. Symptoms were incision gradually progressing with no any specific aggravating or relating factors. 1P score is given. Nocturia 2 times per night.
So now see here, what has happened is what the patient has told. He had poor flow, he has
Yes,
increased
sir.
frequency,
Frequency.
and then he complained of hesitancy and urgency. So
It
whatever the
is,
patient's complaints are, that has been recorded first. And then
yes, sir.
you run through the IPSS score because you want to evaluate that also, right? So,
Yes, sir.
yeah. चलो जी आगे जाइए.
No any burning micturition, immature urethria, no previous instrumental catheterization, no abdominal pain, vomiting, fever, no bony aches, bony pain, weight loss, no any puffiness and limit.
चलो,
Then
very
I
good.
would
हाँ,
like to
बोलिए
know
बोलिए.
about the past history of the patient, family history,
Correct.
and personal history of the patient.
It's there on there. Anything
Sir.
contributory? Nothing. Okay, he's on aspirin
Yes, aspirin.
and
And
IHD.
sir,
Yeah,
also he's non-smoker.
right.
Then, sir, I would like to do the general examination of the patient.
तो जनरल एंड फिजिकल एग्जामिनेशन साथ में बोल
Examination,
दीजिए ना.
yes, sir.
हाँ,
General and physical examination of the patient.
करेक्ट. बता दो भाई.
Yes. So patient's average general examination was normal.
Yes, sir.
On physical examination and local examination, external genitals and no circumcised penile meatus, but bilateral predictable hernias were present.
Yes.
Rectal examination was done. Prostate was grade 2 enlarged, forming consistent smooth surface, no tender, and medial sulcus was palpable. No any blood on those. Rectal mobile mucosa mobile and rectum was empty.
Yes.
On deep examination for abdomen palpation and everything, there's left-sided complete reducible direct inguinal hernia and right-sided incomplete reducible direct inguinal hernia was present.
ಹರ್ಷದ್ ಮದ್ವೆ ಆಯ್ತು ಈ ವೀಕ್
ಹ?
ನಾಗತ್ತ ಹೋಗಿತ್ತಲ್ಲ
ಯಾರ್ ಮದ್ವೆ ಆಯ್ತು? ಯಾರು ಹರ್ಷಿತಾ ಅಂದ್ರೆ?
ಅದೇ ಮಲ್ಲಾಂಟಿ ಗೊತ್ತಲ್ಲ ಅಲ್ಲಿ ಅತ್ತೆ
ಹಾ
Respiratory examination was normal. CVS1 is no any murmurs anything. CNS was normal.
Okay, now what do you want to do?
Sir, now I would like to do, sir, urine routine microscopy, renal function test, complete blood count, with serum electrolyte, as well as, sir, I want to do USG, abdomen and pelvis with uroflowmetry.
Very good. So I wanted you to say that routine general
Yes,
investigations plus sonography and uroflowmetry. बताइए।
Uroflowmetry.
And a serum PSA at this point.
So hemoglobin was 11. WBC
So very
count
good. Somebody said serum PSA.
See, yes,
Yes, sir.
Okay.
serum PSA was raised 7.28. B1C 6.2 and D was also done. Ejection was 55%. Sodium was 134. Potassium was 4. Rest everything was fine. Serum
So
create was 0.9.
now what do you think?
sir, as serum PSA is in between 4 to 10 nanogram per ml. So, sir, I would like to again add some PSA density and free PSA values also to.
Clinically, what do you think? It is a short history. PSA is
Sir,
raised
short history
and DRE was
PSA.
normal.
Sir, it is mainly due to the prostatic enlargement, and that also have some component of
देखो जी
infection.
बेटा ऐसा बोले ना एग्जाम में कि प्रोस्टेटिक एनलार्जमेंट तो फिर they will go on percentages. How many times you see prostatic enlargement with raised PSA?
So patient with a 2 month history, sir, of LUTS symptom along with raised PSA. We would like to keep a diagnosis of, say, prostatitis first, sir, with the
Very
PSA
good.
of 7 from
Yeah.
PSA.
Can be. One of the possibilities is prostatitis.
But however, presently the patient is asymptomatic, sir, related to prostatitis. There is no dysuria, there is no fever, sir. And so we would like to investigate the patient further, sir.
Yes.
We got the urine routine micro. Urine routine micro showed innumerable pus cells. Occasional RBCs. Further, we did in culture insensitivity. Culture showed Morganella morgagni, and it had following antibiotics susceptibility.
So now next what? What do you want to do?
Ultrasound of abdomen pelvis, sir.
So Santosh, can you read?
Sir, this is a ultrasonography of KUB, kidney, bladder, and prostate, sir, and urinary bladder and prostate, sir. In this kidneys, corticomedullary differentiation is well made, sir, and I'm not seeing any pelvic ulcer dilatation. In the bladder
See, now, when you are asked by the examiner to read this film, very nicely this film is marked. There is liver, gallbladder, then they have shown even spleen.
Other solid organs were normal.
So then you are saying KUB, है ना? फिर unnecessarily irritation
Yeah,
होता है.
yes.
तो
It's an
क्या
ultrasound
है?
abdomen.
Just make a passing comment. No?
Comment.
We don't want you to
Yeah.
go into the details of that. Just make a passing comment that rest of the abdomen organs are normal.
Rest of abdominal organs like liver and gallbladder, pancreas were essentially normal, sir. There is a
Correct.
cyst
Then
in
they are very clearly showing you cyst. तो आप उसके बारे में कुछ बोले ही नहीं cyst के बारे में.
cyst. There is a cyst. Anechoic
है ना?
hypoechoic lesion is present in left kidney, right kidney, sir.
Small things we want you to go ahead, right? Not get stuck on
Yes,
that.
sir.
Okay.
Yes.
Suppose it was a complex cyst, then it would become an issue. You have missed it.
Yeah, sir.
You
Then
have to make a note of every small detail. Now you are at super specialty level. Okay.
Yes, sir.
Yeah.
Yeah.
And bilateral
Doctor-
hernias were also visible.
Dr. Maheshwari, will you like to give some information in ultrasonography in prostate?
Sure, sir. But first, let's get what these people read, and then we'll answer. Hello.
Yeah.
Sir wants you to comment about the prostate. So you have to comment about the prostate. So by now, we are dealing with lower urinary tract symptoms and difficulty in voiding. So you have to comment on that.
Prostate is visualized with the dimensions not exactly mentioned. He's looking enlarged itself, and there is in one film, in last film, there is an intraprostatic extension. We can note, sir.
And associated with inguinal hernia also they have mentioned in plates.
Are you happy with this sonography?
Sir, bladder is very little field, so at least 100 to 200
To comment on
ml of
this,
bladder.
the bladder should be minimum of 250 ml or 250 to 300 ml. It's not fully distended.
Right. So what happens when you do a sonography at an empty bladder?
And what would you want to look at with that 150 to 100 ml?
The bladder wall would appear thick and maybe irregular if it's not an adequately distended bladder.
Yes,
so for a poorly distended bladder, we may confuse it with the thick. We may interpret it as a thick bladder wall. So we want it to be adequately full to comment properly on the bladder wall.
So you are interested in looking for the bladder wall thickness.
Bladder wall thickness, yes.
And
again, I am giving you a hint. Sir is interested in prostate.
Sir, intraprostatic protrusion of the median lobe, we should look for that.
Very good. So that is seen at the minimum level of 150.
150.
Yeah.
Okay. Now, what are the other things that you would look for to assess bladder outlet obstruction in abdominal sonography? So one thing we have said is IPP.
Yes.
What
Yes,
are the other things?
Angle, sir, the prostatic urethral angle with prostate, if it is more than 35, it is possible outlet obstruction is present.
And sir, bilateral
I did not understand what you said.
Bilateral upper tract changes can be there, sir, due to the bladder outlet obstruction. Also, bladder wall will be somewhat thickened with irregular nature, or we should look for any diverticuli, pop-up mechanism for the bladder outlet obstruction.
What was that comment on 35? We didn't understand.
Sir, the prostatic urethral, if you make a line with prostatic urethra and prostate, the angle, if it is acute, then if it is more obtuse, then it is possible below. There is a possibility for.
So how much is the prostatic urethral angle? What is the normal prostatic urethral angle?
Sir, 35 degree.
35 degrees is a very acute angle, beta. is means the prostate and urethra have a 35-degree angle. 35-degree will be like this.
You understanding now what sir is telling?
Yes, sir. Yes, sir.
So 35 is a correct figure, but that is the figure for the bladder weight.
Okay.
Okay. So less than 35 grams bladder weight is non-obstructed, and more than 35 grams is obstructed. Okay. Anyway, so in sonography, as we have said, we will, you see, again, as Dr. Hiren has been telling you, have a system of talking. Either come from above downwards or go from below upwards. So let's come from above downwards. Hydronephrosis, thickened bladder wall, diverticuli, post-void residue, IPP,
Stone.
then bladder wall, bladder weight. Then we go for the prostatic shape, and last we go for the prostatic urethral angle. Okay, there is one more parameter which is looked at, which is called as PCAR. PCAR. Any idea what that is?
Basically, it is the pressure circle area ratio, sir. So it
Presumed circle area ratio.
is
Not pressure.
So we take the maximum horizontal diameter of the prostate, sir, and we draw a circle of that diameter, and we superimpose that circle over the shape of the prostate, and then we try to compare the shape with the actual prostate shape, sir. So if it is less than 0.7, then it is usually something which is non-obstructed. But anything more than that, it could be tending towards obstruction.
Good, perfect.
Very
Absolutely.
good. Very good.
What about the angle?
Haji?
There is some formula about the angle also, right?
There is
The
a
bladder-
prostatic urethral angle. And if I remember it right, I will want somebody to recheck it. But I think it is 110 degrees, less than 120 or more than 120. It is definitely not 35. But I will need to reconfirm this figure. I don't often remember that.
Right. So now looking at this sonography, what is your conclusion and what else we want to do?
So one thing is we don't have a full bladder and a post-void residue image in this sonography. So that would be something that we would be wanting, sir. Here, so.
Right. Okay. So Brijesh, show them the report.
Gallbladder was normal. CBD was normal. Spleen was normal. Right kidney, parenchyma, congenital peritoneal system of both the kidneys are normal. No evidence of hydronephrosis or calcium calculi in the both the kidneys. Cyst of 2.4 by 2.0 centimeter noted in mid pole of the right kidney, and another cyst of 1.8 by 1.12 centimeter noted upper pole of the left kidney. Ureters, both ureters are non dilate, hence not seen on sonography. Prostate was enlarged, smooth margins, homogeneous parenchymal echo textures. Weight is around 42 grams. Internal calcification in the midline. Bladder is normal capacity. Bladder wall thickness is normal. No evidence of mass or lesion or calculi. Pre-void 367, post-void 51 cc. Inguinal region, the right inguinal reducible hernia of 2.8 cross 2.7, 2.27 centimeter with 1.5 centimeter projective on Valsalva technique, and left-sided large hernia of 2.7 centimeter gap
So
of
basically he has, see Brijesh, basically he has got an enlarged prostate.
bilateral
There is a
inguinal.
residual urine of 51 cc and he has got bilateral inguinal hernia. So these are the findings. Okay, Santosh. Now what you want to do?
We'll do a uroflowmetry, sir. We'll see.
Okay,
I'll
one
ask for the
minute.
uroflowmetry.
Okay, Brijesh, show him uroflowmetry.
The uroflowmetry patient voided around 156 ml of urine, sir, with a Umax of 10.7 ml per second, and average flow was 4, sir. So the patient is having obstructed pattern of urine maturation, sir.
So what you conclude from this uroflowmetry and from ultrasonography, these two, what you conclude? In ultrasonography, you think there is a median lobe?
There is no median.
Yes. Sir.
Intraprostatic extension was present, sir.
So it was there. And now you are seeing this interrupted flow.
Yes, sir.
Do you have
Interrupted flow
any
is there with
coordination?
obstructive pattern.
So this is a, so what type of pattern? So what do you suspect?
Bladder
No.
outlet obstruction due to median lobe of the prostate, prostatic enlargement, sir.
Okay. Fine.
How do you come to the conclusion of median lobe?
Don't forget the PSA.
The patient is having a gray zone of PSA also, sir.
Yeah. No,
But the patient is
Maheshwari
having
has asked you.
UTI.
Maheshwari has asked you, Dr. Maheshwari asked you, okay, why you are concluding that there is a medial lobe enlargement which is causing obstruction? Yeah, anyone? Aditya or Rahul can. Rahul, you can answer.
Sir, there may be possibility of the stricture disease, which can also give rise to the interrupted
So in
pattern
a stricture,
the
what type of
uroflow.
pattern you will see?
Sir,
We see box type of pattern.
box type.
Box type. So in this case, you think it is a box type?
No, sir, this is interrupted, but one of the possibilities.
Yeah, no. Dr. Maheshwari asked you very, straightforward question. That's looking at sonography, he said that there is a medial lobe which is causing obstruction. If you want to justify in exam, you have said that. Normally, it is better not to avoid all these things. But suppose if you have said this in exam and you want to justify, how you are going to justify?
Sir, points in the history, patient has difficulty in urination. That is, patient is having voided symptoms, as well as in the laboratory report, patient has serum PSA, which is raised. And in sonography, there is an enlargement of the prostate, specifically median lobe. And in uroflowmetry, it suggestive of interrupted pattern, which is pointing toward the bladder outlet obstruction, maybe due to the prostatic enlargement.
Yes, I thought yeah, go ahead. Somebody was saying something.
Intermittency that is there in the uroflow curve that is suggestive of that obstruction due to the median lobe.
I would say let's not get into this, Pushkar. Means this is too much dissection of the uroflowmetric curve.
Okay, sir.
Means I would say, why is this not a pattern of, say, hypocontracted detrusor? Okay, intermittency is possible in that also. Okay. So the sonography is a suboptimally done sonography. Even the radiologist has not reported a median lobe, and we are diagnosing median lobe based on uroflow is too much excessive reading of uroflow.
I agree with sir.
Yes, sir.
We can't do that.
All you should say
Sir.
is that means okay.
Sir,
Again,
but
yeah, but
sir,
please.
In plate there is nothing in the bladder, sir, urine. But in report he reported as pre-void is 357 something, and post-void around 57. So, sir, there is some discrepancy between the plate and report.
So it is possible that they have not shown us all the images, so we accept this.
Yes.
But at least whatever images have been shown to us, based on those images, do you see any IPP?
No, sir.
Okay.
Not at all.
IPP is not there. So
Not
we have to
there.
remember to ask for it. Sir is just trying to draw your attention that when we ask for sonography, we should ask for these details. Gaurang sir, I think Umesh Oza sir has joined. I think we should welcome him and make him co-host.
Yeah. Yes. One second. Huh?
Gite Saab is very silent today.
Yeah.
It is the silence before the storm.
एक्चुअली
उमेश ओझा
आपने बोल ही दिया तो शुरू हो जाता हूँ।
बिल्कुल।
यूरोफ्लोमेट्री पे प्रोस्टैटिक इंट्राप्रोस्टैटिक प्रोट्रूजन है वो डायग्नोस करना उतना इजी नहीं है, और वो करना भी नहीं चाहिए स्टूडेंट लेवल पे. दैट इज वन. Another thing is, last but one film, there is a small intravesical prostatic protrusion oblique film है, उसमें है नहीं, ऐसा नहीं है. लेकिन when it is classified, it is less than 5 millimeter, 5 millimeter to 1 centimeter, and more than 1 centimeter. ऐसा उसका classification है. So it may be mild, may not be causing problem, or may not be having like a ball valve mechanism. जैसा कि कंप्लीटली वो ब्लैडर का नेक जो है वो कंप्लीट ब्लॉक करने जैसा सिचुएशन इतने छोटे से प्रोस्टेटिक प्रोट्रूजन से नहीं होगा. So that much significance should not be given in this particular case to the intraprostatic extension. Another thing, last शुरू से ही कुछ चीजें ऐसी है कि जो by primarily someone has asked PSA. So without knowing the post-void residue, without knowing the urine, at least one urine report. So multiple pustules बाद में आया, so that itself suggests that there is a rise in PSA maybe due to infection. So PSA should not be a primary investigation to be asked in case of BEP. That's what I feel. अगर सर कुछ चेंज है तो बोल सकते. दूसरा बात,
डॉक्टर गीते आपकी आवाज नहीं आ रही है.
I think his connection is lost. मतलब it is not proper.
Yes, even what he spoke about PSA, I couldn't hear exactly.
Okay.
No, he said, sir, PSA in primary BEP, maybe we should not ask. That is what he was saying.
Okay, he may join back. Let us go ahead. So,
So now, could somebody summarize where exactly we stand and what's your plan?
So this is an elderly male patient, sir, with moderate IPSS symptom score, sir, having a history of 2 months duration, with the investigation showing a PSA slightly raised of 7, sir, with some features of bladder outlet obstruction, mostly because of enlarged prostate, along with bilateral inguinal hernias. Sir.
And culture positive.
Culture is with culture positive.
So now, what's your plan?
First, we will give an antibiotic with the calcium antibiotic for 1 or 2 weeks. Then we repeat the PSA.
Do you want to give only antibiotics or also put him on some?
And treat the LUTS also, sir.
So what do you want to give for LUTs?
The patient is having a prostate of size 42 cc, sir, 42 grams. So it is more than 40. So alpha 1A blocker plus 5-reductase inhibitors.
Okay. Right. This becomes a bit of a debatable issue. You see, we know that 5-alpha reductase inhibitors also reduce the PSA. So unless you take a call about the management of raised PSA, it is better to avoid starting 5-alpha reductase inhibitors. Okay. So in this patient, I would put him on antibiotics because the PSA is elevated, there is pyuria and culture is positive. I would put him on alpha blocker and observe him and see, maybe repeat a PSA after some time.
Okay. Perfectly agree. So now let's see what they did.
So now, see, in this case, there are 3 important things. As Dr. Maheshwari said, there is an infection. Number 2, there is a enlarged prostate with only 51 cc of residual urine. So normally, everything, whatever we decide about a prostate, we can do. But this patient has got bilateral inguinal hernia and the general surgeon is saying that he wants to operate and he has sent this patient to you. Now, in that case, how we are going to work out?
Sir,
And PSA is
bilateral.
raised. And PSA is raised. So tell us in the sequence.
Sir, bilateral inguinal hernia maybe due to complication of bladder outlet obstruction. So we should, considering this patient, we should give the lifestyle modification to the patient, behavioral modification, along with 2.5 liters to 3 liters of water, antibiotics, and alpha blockers. After that, we will assess the patient, and then, sir, definitive management about the inguinal hernia should be think.
So,
Okay,
beta,
so
you
what we are
addressed
saying,
only the inguinal hernia and his LUTS, but patient is anxious about his PSA. So you need to
Sir,
also explain him
sir,
that right now
repeat-
there is infection. So I would like to
Yes, sir.
repeat it again, reassess.
Yes, sir.
So
PSA
don't
should
forget the PSA. Okay. So you
Yes,
say all
yes,
that,
yes.
all the whatever you said, just add to that you will want to repeat the PSA after the course of antibiotics.
Yes, sir.
Okay.
Brijesh,
go ahead.
Second scenario. 78
Sir,
year
one
old.
doubt here.
Nay, what was done? What we have done in this patient?
TURP with laparoscopic left.
Yeah, okay. So
Yeah, please go ahead. Whosoever is, what is happening?
So there was one doubt, sir. in this case.
So sorry. In this case, patient had not improved, and we already kept him on alpha blocker. We treated his infection for almost like after 1 month, but he had not improved, and clinically also he was not very happy. So we did prostate surgery, and the general surgeon has done his hernia surgery.
So Brijesh, you were supposed to say this. You have to give the summary also. That what
And,
was
sir,
managed, how it was managed, and why it was done. Like
Yes.
what sir has explained. Okay. Yeah.
Yes, sir. Yes, sir.
Sir, supposing the patient would have improved after a month of our medical management, sir, and still the patient would have been planned for an hernia repair surgery. So should we, considering it to be secondary to enlarged prostate, consider the surgery of prostatic enlargement, or we can just continue the medical management for the same, sir?
So let me ask you this question, Aditya.
Yes, sir.
What are the absolute indications of surgical intervention in BPH? Does hernia feature in that?
No,
sir.
sir.
No.
No.
So the answer is there. Okay.
Okay, sir.
So you do not take decision of BPH based on hernia. You take decision based on his
Bothersome.
bother score and the complications, which are indications for intervention. Yes. as
Also,
sir
I would
said-
like to add to sir that can you name one more relative indication? Like sir said, this is not an absolute remedy. So if
But,
the
sir,
patient had a
patient-
bladder stone, suppose patient had a bladder stone,
Right.
is it an absolute indication for TURP?
Relative indication, sir. It's
Relative
so
indication.
previously it
Correct.
was.
So now they are saying that you can manage the prostate medically. So same way, sir said that hernia can be managed. So it is not an absolute indication. What are the absolute indications?
Recurrent
Recurrent UTI
retention.
and
Again, beta, you have to start from upper tract, no?
yes, sir. Upper tract involvement with raised triad, sir,
Very good.
and recurrent acute urinary retention, which is not amenable with medical management, and
Two failed trials.
Two failed trials, yes, sir. And recurrent bladder stone, sir.
in 1 year.
Before answering what to be done for this patient, here there are 3 to 4 points. One is the infection symptoms, and third is a hernia. Okay, and fourth is a PSA. So all 4 points you have to take into consideration. So first thing what I will treat is infection. So I will start antibiotic. I will start on alpha blocker. I will repeat the PSA after some reasonable amount of antibiotic after giving the antibiotic. So for 2 weeks, my pattern is 2 weeks. So after 2 weeks, I will repeat the PSA. If it is normalized, okay. Then urine culture specific antibiotic. So urine should be free of organism before going to the TURP. If you are planning the TURP. So control of infection, starting the alpha blocker. Hernia urgency नहीं है. Bilateral hernia है, that means definitely it is a bilateral. Direct hernia रहने का ज्यादा चांस है. ओल्ड एज की वजह से वो कुछ कॉम्प्लिकेट होने का भी चांस कम रहता है. तो उसको अर्जेंटली आज ही करना है, नहीं तो नहीं होगा बाद में, ऐसा कोई अर्जेंसी नहीं. तो पहले है इन्फेक्शन, एंटीबायोटिक शुरू करो, अल्फा ब्लॉकर शुरू करो, रिपीट पीएचडी करो, नॉर्मलाइज हुआ कि नहीं देखो. मैलिग्नेंसी मेरे लिए प्रायोरिटी है. फिर उसके बाद में डिसाइड करो कि अभी ये इन्फेक्शन कंट्रोल हो गया है, तो व्हाट आई हैव टू डू. तो पीएचडी कितना है. सपोज पीएचडी इज स्टिल हाई, then you have to go behind that pH.
So what did we learn from what sir told?
Provided that pH should be less than 75 year and all the basic required things for going behind the pH.
So just in a nutshell, what did we learn from sir's comments?
वो अगर समझो नॉर्मलाइज हो गया, और पेशेंट के प्रोस्टेट के सिम्टम्स इंप्रूव नहीं हो रहे, तो TURP is not based in my practice only on one point. There are multiple factors. Severity of LUTS, bladder wall thickness, intravesical prostatic extension, PSA, ये सब चीजें, पोस्ट वाइड रेसिड्यू, ये सब चीजें एक साथ करके एज अ वन उसको सोचना है और फिर डिसाइड करना है कि इसको देना कि नहीं, TURP करना कि नहीं करना. तो जब भी एग्जाम में कुछ भी आंसर दे रहे हो, उसका अगर तुम्हारे पास बैकअप रिप्लाई नहीं है तो फंस जाएंगे. तो सोचना है और फिर बोलना है.
What I wanted to say is that if you saw sir made up in his mind what are the problems we are dealing with and how you address them one by one. So this is the way systematic thinking. Okay, so we're just trying to make you think. What did sir do? He drew the problems. Okay, 1, 2, 3, 4, and what all, how you will address each one of them.
Yes.
So all of you understood, na, why we have kept this case? Because the PSA is high, because the patient has got infection, and patient has got bilateral inguinal hernia. So considering all these things, there are 3 different scenarios how you are going to answer this. Right? So now I hope that all of you understood from Dr. Gite, Maheshwari and Hiren Sodha's talk that how we are going to answer. Fine?
Yes, sir.
Okay, let's go to the second case.
Okay. A 78-year-old male came with a complaint of difficulty in passing urine since 1 month and fever since 10 days.
I would like to elaborate his presenting complaints, sir, in the form of the IPSS score, and also regarding the fever, whether it was associated with any dysuria, whether there was presence of any flank pain, burning micturition, all these are there or not. I would like to take important negative history and also ask about any prior events, significant events that could have been like any past episodes of retention and all those. I would like to ask. First, I would like to elaborate the presenting complaints.
Okay. Patient was apparently asymptomatic before 1 month, started developing difficulty passing urine, increased frequency every 1 to 2 hours with assistance and urgent factors 24 as we mentioned. Fever was intermittent with 2 to 3 episodes in a day, not associated with chills or
Brijesh, your connection is not good. Are you moving around or what? Swastik?
No any history of burning mixture and
Okay, so there is no history of burning micturition, hemorrhage. Yeah. Bridges, go ahead.
So the patient has moderate LUTS symptoms, sir. And regarding this fever could be because of any urinary tract infection. It could be because of like the ascending infections, upper tract changes. So I would also like to know any significant events, if there is urine retention, whether any episode of acute or chronic retention was there or not.
Brijesh, we are not able to hear you. Swastik?
Bridges, now you are a co-host.
hello.
Yeah.
Okay.
No. Okay, go
So
ahead.
he didn't have any history of burning mixture, immature lithuria, or no any instrumental catheterization, no abdominal pain, nothing, no back pain, or no weight loss. So he has a known case of diabetes on regular insulin and hypertension since 10 years and taking on telmisartan 40 milligrams OD. No any previous surgeries. Family history was not significant. He was vegetarian by diet and everything was normal. Sleep cycle was disturbed because of nocturia. General examination, patient was everything was normal. No any evidence of atrial sinus clubbing. No lymphadenopathy, nothing normal. Local examination also normal. On rectal examination, prostate was grade 2 enlarged, smooth in surface, but there was tenderness on doing per rectal examination.
Bolo ji, now
Hello?
summarize the positive findings from the history
So
and
sir,
He is an
examination.
elderly male, sir, with LUTS and a history of fever, and is
Treated
the
with
patient is known
antibiotic.
diabetic. And on examination, patient is having tender rectal examination. So yes, sir, this is positive. It is provisionally by this time it can be due to a prostatic abscess, sir.
How do you clinically differentiate between prostatitis and prostatic abscess?
Prostatic abscess patient will have fever with chills. Prostatitis,
Does not have fever.
Anything on examination?
Based on DRE findings, sir, we can differentiate. So if on DRE finding it's only a tender prostate, it is more towards prostatitis. Sir. But for an abscess, you would be having raised local temperature at the site of the prostate, sir, along with maybe a baggy feeling that we may be able to palpate on DRE.
What do you mean by raised local temperature?
How will you judge local temperature per rectally?
बॉगी फीलिंग बराबर था, रेस टेम्परेचर बराबर नहीं है भाई।
टेम्परेचर
वैसे भी कोर टेम्परेचर ज्यादा ही होता है आदित्य।
रेक्टम में तो टेम्परेचर ज्यादा ही रहेगा ना भाई। हाँ बेटा, बॉगी फीलिंग वाज ओके
as compared to the surrounding.
Prostatic abscess fever with chills, continuous fever.
देखो, before doing the prostatic examination, the following things should be come in your mind. One is a prostatitis, voiding symptoms, old age, diabetes, and fever with chills. तो 3-4 डायग्नोसिस दिमाग में आना है। प्रोस्टेटाइटिस रह सकता है, पाइलोनेफ्राइटिस रह सकता है। हमने अभी पीआर नहीं किया, सिर्फ क्लिनिकल एग्जामिनेशन पे अगर बात कर रहे हो तो इट इज ओनली अ कॉम्प्लिकेटेड सिस्टाइटिस रह सकता है, उसमें भी फीवर विद चिल्स आ सकता है। प्रोस्टेटिक एब्सेस रह सकता है, ठीक है ना। तो ये 4 चीजें ध्यान में रखने के बाद में पीआर हो गई। पीआर पे अभी टेंडर आया, तो फिर व्हाट आर द 2 पॉसिबिलिटीज नाउ, प्रोस्टेटाइटिस एज वेल एज प्रोस्टेटिक एब्सेस, दोनों रह। जब टेंस एब्सेस रहता है तो वो भी टेंडर और फर्मी लगता है, डिफरेंशिएट नहीं कर सकते प्रोस्टेटाइटिस और प्रोस्टेटिक एब्सेस में until and अदरवाइज वो पूरा वेल डेवलप्ड एब्सेस हो गया है और बोगिनस फिंगर को लग रहा है, या फिर रप्चर हो गया और कुछ साइंस आ गए। तो आज अभी ये पॉइंट पे तो प्रोस्टेटाइटिस एंड प्रोस्टेटिक एब्सेस दोनों रखना है और आगे फिर बढ़ना है और कुछ इन्वेस्टिगेशन करने के लिए।
So we have got Dr. Oza with us, so we can ask question to him also.
Good evening, sir.
Good evening. No, please go ahead, Gaurang. This time, let me listen. Okay. If anything particular, I will. But just let me listen. I'm enjoying it.
Okay, sir, good evening, sir.
Good evening. Good evening. कैसे हैं आप?
Good evening, sir.
Good evening. Please go ahead. Please go ahead. Thank you so much.
सर आप एटलीस्ट वीडियो तो ऑन कर दे, हमको दिखना तो चाहिए।
उनको देखने तो कम से कम।
जरूर
सर।
Okay, go ahead, Vijay.
Coming back to this, you see, remember that prostatitis means before going to frank prostatic abscess, there are usually small multiple micro abscesses. And it is clinically not possible to differentiate between prostatitis and multiple small micro abscesses. Okay. So tender prostate, don't jump to prostatic abscess just because he has fever. It can very well be prostatitis, but yes, if it is not boggy, it doesn't rule out abscess.
Hemoglobin is 12.5. WBC count was raised 14,000. Serum PSA was 7.24. Its BMC was 7.1. 2D was normal. Sodium and potassium.
So doing a PSA in a 78-year-old male with fever and chills and voiding symptoms and tender prostate after on clinical examination, is it okay for all of you?
No, sir.
As far as exam is concerned, you should not be okay. So it is not necessary to do a PSA primarily in this patient, because already the things is explainable and it is going to definitely high only.
Can you justify if you have done a PSA? Sir is telling not required, but I am saying, can you justify if you wanted to do a PSA?
If it is due to the infection, then later we can compare it with the previous case.
Correct. So it will show the response to treatment, right? So if PSA is high, so if you have a very high PSA and it comes back to normal, then you know that it is because of prostatitis.
It must be due to the infection.
And whether it's responding or not.
But I would still feel, Hiren, that from day-to-day practice as well as exam point of view, at this time, they should not be asking for PSA.
Correct, sir. I was just telling lateral thinking.
Yeah.
Yeah.
अगर पूछ लिया तो that's a good
जी
explanation.
जी जी
But if Gita Saab is your examiner, he will tell you that you can look at the progress even by improvement in symptoms, improvement in fever. ठीक है?
Yes, sir.
You don't need PSA to look for improvement. मैं नहीं बोलूंगा, ऐसा गीता साहब बोलेंगे.
Right, sir.
The only problem is sometimes people see this PSA and start doing biopsies. That is a little worrisome.
Exactly.
Correct.
Chale, so what next?
Within routine had parcels 16 to 18 by high powerful and RBCs 10 to 12 high powerful. And culture and sensitivity report didn't show any bacterial growth.
अरे रुक जाइए भाई, उन लोगों को पूछने तो दीजिए क्या चाहिए.
So if I am an exam going student, after completion of the history, I will definitely tell I will admit this patient. I will start the antibiotic and then send the urine culture. But urine culture and antibiotic parallelly. I mean.
Sir, there was some history that he has received IV antibiotic by the local family physician.
By local.
So can be a culture on antibiotic.
Correct,
if
sir.
he has received, because fever is still there, so still you have to go for culture. क्योंकि अगर ये सब चीजें ओपीडी पे ही कर रहे हैं तो एग्जामिनर अननेसेसरी पकड़ के बैठेंगे वहां पे कि आपने अब तक तुमने एडमिशन बोला ही नहीं. तो ध्यान रखना है, जहां जरूरी है वहां पहले बोल देना.
You see, it's an old patient, diabetic, raised total count, presented with fever for 10 days, significant symptoms. This patient deserves hospitalization and injectable antibiotics. And especially when there is no improvement with oral antibiotics that were given by the primary physician, definitely you need to hospitalize and take care of this patient. So how will you choose your antibiotic for this patient? You have hospitalized it. How do you choose the antibiotics?
Primarily, we'll want to use an antibiotic which has more concentration in the prostate. So if we have a prostate culture-specific antibiotic, then in that list we want to look. In this case, as there is no culture-specific antibiotic, you would want to choose an antibiotic which is prostate-specific.
So proceed now. Which ones?
So fluoroquinolones are preferred, sir. Then sulfonamide. Then Septran can be used, sir. That is cefuroxime sulbactam. Septran can be used, sir. Then tetracyclines are again a good antibiotics for prostate specific. And injectable, maybe we can use cephalosporins as well, and erythromycin.
So there was one mnemonic which you people had told me. What is that?
SOFT, soft CET, sir. So sulfonamides, polyandomycin, fluoroquinolones, then tetracyclines, and again cephalosporins, erythromycin, and again tetracycline. SOFT, soft, and CET.
Can I say something?
Yes, sir.
I think when the question is asked that what antibiotics you will start, see, I think Pankaj made it very clear that this is old man, diabetic, and now with high fever. I don't think you can talk of the antibiotics you talk which are more orally given.
Orally given.
Here you must realize that is a serious condition. And in elderly diabetic people, they can go to septicemia in no time. Now, the fact that you are admitting it means that this patient needs proper monitoring. And the first thing is injectable antibiotics. Because if you start with whatever list which you gave, it doesn't serve the purpose in this clinical situation. So I think when a specific question is asked, the examiner wants to know that as a urologist, tomorrow patient comes to you, what are you going to do? That's what examiners are interested in, your practical experience. The list which you gave is given in the books. I mean, I don't think that we need to know that. What we want to know that when patient comes to you, is he safe in your hands and are you taking proper decision? So I think, and you all have worked in the ward, so don't go by books. I think if you say what you are doing regularly, you will be right. So don't worry about it. You need not all the time give theoretical answer. So I personally feel you should be very specific. I'll admit the patient, do whatever test, start X, whatever you are going to write in the prescription, what test you will send. All that, I think if you give a clinical picture, examiners will be more happier in your practical examination. Thank you. Go ahead, please.
So I totally agree with Oza sir. But if examiner asks, until and otherwise the examiner asks, what are the prostate specific antibiotics, then you have to tell.
I agree. I agree on that.
But primarily answer should be what sir, on the line of what sir says.
Fine. Okay. So Brijesh, go ahead.
Yes.
So Santosh, what else you want? Now, this is a
Ultrasonography, first we'll ask, sir.
Yeah.
USG,
So
sir.
you know ultrasonography, you know the culture report, you know what is the uroflowmetry, you have admitted the patient, you have started IV antibiotics. Okay.
Sir.
What you are expecting, when you will do any other test, or you'll just admit him for 5, 10, 15 days?
What is the purpose of doing a uroflowmetry at this juncture in this patient?
To see the resolution of symptoms, like after 40, to see the resolution of symptoms.
So already ultrasound is done.
Sir, if ongoing infection is there, we can postpone the uroflowmetry.
So it is not needed at this time in one
Yes,
line.
sir. Yes, sir.
So if someone has a prostatic abscess or severe prostatitis, how he is going to pass? Normally, how he passed naturally? Is it possible?
No.
So it is definitely result will be false.
So, but at this time we definitely need a ultrasonography. Why?
Ultrasonography, sir.
Why do we need a ultrasonography?
To see
What are you
to see
trying
the
to
abscess,
do
sir.
from sonography?
Sir, exactly localize the infective focus.
Okay. What do you mean by
And,
that?
Sir, organ of origin of infection, we can see in ultrasound abdomen pelvis, whether it is prostatitis or enlarged prostate or prostatic abscess is there. Yes, sir.
You see, clinically, you have diagnosed the source to be in prostate. Means why do you need a sonography to confirm that? And will you do abdominal sonography or a truss?
That is contraindicated.
Truss is contraindicated. Perfect. So there is no place for truss. So then why are we doing abdominal sonography?
Sir, looking for any pelvic abscess, pelvic collection, which can lead to the prostatitis or which can lead to the fever with chills, any other cause.
To see any cystitic features, sir.
Have you confirmed that this patient has a prostatic abscess? Already sir told there is a transrectal ultrasound is contraindicated just now. So what are the other way to confirm that is only a prostatitis, only microabscesses, any other pathology in the prostate or abscess? Well developed abscess. ये कैसा पता चलेगा?
So doing USG abdomen pelvis.
So that's what sir is asking, like why you want to do abdominal sonography? दूसरा कोई रास्ता है क्या?
So definitely we are not looking at any pelvic abscess. You see, pelvic abscess with prostatic abscess is so unusual. Means in my so many years, I have not seen it. Okay, don't talk of such unusual situations. Okay, so ultrasonography abdominal may be able to pick up if there is an abscess cavity. But at this time, more importantly, I am interested in knowing is the patient emptying his bladder properly.
Exactly. Retention. Huh?
So that is the most important thing I want to know at this time, because I want to confirm that bladder is emptying well. So ultrasound will tell me how much is the post-void residue, and it will also tell me whether there is any formed abscess in the prostate. किया है भाई अल्ट्रासाउंड, क्या है अल्ट्रासाउंड रिपोर्ट?
Ultrasound did not show any sign of prostatic abscess, just it showed the prostate was enlarged with 34 grams and pre-void was 480 ml, post-void is 42 ml. Bilateral kidneys were normal, no any bladder was also normal.
Perfect. Now what next?
So along with antibiotics, you would want to add a few other drugs, like you want to add an alpha blocker, an anti-inflammatory, and ask the patient to do hot sits bath. That would again give him symptomatic relief.
Right, sugar control.
Yes, strict diabetes control is also extremely important. Okay, so over next, say 3 days, his fever stabilizes. Now, last 24 hours, there is no fever. He's voiding satisfactorily. His PVR has remained same. Now, what do you intend to do next?
So Aditya, what you will do?
So we would like to, once the patient is symptomatically better, sir, and he is AFib for 24 hours, we can continue the antibiotic management. So we can shift the patient to oral antibiotics and plan for discharge of the patient, sir. And on follow-up, then we will ask the patient to follow up after 1 week, see his symptoms, sir, and then take.
और कुछ पूछना चाहते हैं डॉक्टर गीते?
So now this
Sir,
patient,
is there any role of expressed prostatic secretion इसमें, या फिर यूरिन कल्चर सफिशिएंट है?
No role, sir, of
अभी यहाँ पे प्रोस्टेटिक एब्सेस डायग्नोस हुआ नहीं है. Another diagnosis what we are expecting is prostatitis. So definitely it is acute bacterial prostatitis रहने का ज्यादा चांस. तो प्रोस्टेटिक सिक्रेशंस का कल्चर करना जरूरी है कि यूरिन कल्चर पे काम चल जाएंगे?
Urine culture is sufficient, and this prostatic secretion is also contraindicated probably at this time.
okay. So now this patient, he improved, okay, and he was discharged, but then he came with a retention of urine. Now what you want to do?
So, sir, actually, this patient now, first when he came, this sonography and Euroflow, whatever he showed, that was at initial presentation. So, patient just came with low urinary tract symptoms with the sonography and uroflowmetry, which was done at the outset. Then he was sent with the alpha blockers. He was passing urine well with that uroflowmetry and very minimal residual urine. Then now he has come back.
Now he has come back with urinary retention.
So this PSA is reduced, sir, from 7 to 1. That was after the antibiotic, but he came back with retention.
You want to know the type of retention, whether it was painful or painless retention, sir?
बताइए ना, सोनोग्राफी बताइए ब्रिजेश भाई.
Yes, sir. Prostate was 30 cc. Capsule intact, semivesical, normal, heterogeneous texture with prostatic calcification was present, and pre-void was 800 cc and post-void was 742 cc.
most likely, as per this report, the patient has had significantly amount of fluid, sir, just prior to sonography, which was the
prior to sonography IV fluid पे था कि oral पे था तुम्हारे हिसाब से?
oral. Patient was discharged, sir, so oral fluid.
ये अगर क्लिनिकली जजमेंट लेना है, सुप्रापुबिक टेंडरनेस है, पेन है कि नहीं है, और
Painful retention,
नियर अबाउट
painful retention.
99% यूरिन पीछे, 90% यूरिन पीछे रह रहा है, तो पोस्ट वाइड रेसिड्यू के हिसाब से क्रॉनिक रिटेंशन का क्राइटेरिया में फिट बैठता हो, क्लिनिकली
नहीं
बैठता
सर,
है
he
कि नहीं
came with
बैठता है वो
painful
देखना है.
retention. Sir, he came with
अगर
painful
वो पेन
retention.
अगर पेनफुल है, सो इट इज एक्यूट रिटेंशन. एक्यूट रिटेंशन है तो सोनोग्राफी में और क्या देखना है? पोस्ट वाइड तो पता है, और कुछ? प्रोस्टेट का भी बोल दिया, नॉर्मल लेवल.
Any
Is
other
there
lesion in
indentation of
the
floor of the urinary bladder stage?
क्या बोल दिया?
The prostate is enlarged and indenting the floor of the urinary bladder.
So what happened?
Sir,
If it is
bladder outlet
indenting,
obstruction.
bladder lesion is there or
Bladder
not?
outlet obstruction secondary to
Exactly.
vesical calculus.
इंट्रावसाइकल लीजन्स है क्या, अपर ट्रैक का क्या पोजीशन है वो देखना है, इंट्रावसाइकल प्रोस्टेटिक जो एक्सटेंशन है वो भी कितना है वो भी देखना है. और अभी पेशेंट रिटेंशन में है, सोनोग्राफी हो गई है, हमारा प्राइमरी एम क्या है अभी?
Relieve
him from
the
retention.
outlet.
So I'll give you a hint. Patient had come to the OPD first with LUTS, right? We had diagnosed mild enlargement of prostate with query prostatitis, and because there was history of fever and all that, we had treated him. Then he had improved significantly, went home, passing urine well. Suddenly, since last 2 days, difficulty in passing urine came with this painful retention. Now, thinking about your past history, PSA 7 reduced to 1, antibiotic. Now, what do you think?
Sir, this is prostatic enlargement is worsening, sir, as a natural history. First, he had a lower urinary tract symptoms. After that, he had acute retention of urine.
Here we have a precipitating cause for retention, sir. So we would want to.
What happens to prostatitis when it's treated with antibiotics? All this while you were thinking of abscess, no? What happened?
That may be evolved into the prostatic abscess.
So it is a acute retention with precipitating factor as a recent history of prostatitis oblique UTI. बरोबर है. So n number of precipitating factor examiner ने पूछा तो बोल देना है कि अल्कोहल है, जनरल एनेस्थीसिया, एंटीकोलिनर्जिक और इमोबिलाइजेशन, पीएनआर, जो भी अगर पूछा तो बोलना, नहीं तो वहां से आगे निकल जाना. अभी recently you have given antibiotic and patient passing urine with alpha blocker and get discharged. So that recurrence microabscesses may get coaled with each other and converted into abscesses, and that abscess now as a cause for retention and patient presented with retention. That may be one story. It is true or wrong, we will see. तो ये अपन एग्जाम में बता सकते हैं, considering his recent history, that may be the cause for acute retention in this patient as a precipitating factor.
Brijesh, go ahead. So exactly what happened? Tell them now.
So we were also suspecting such type of scenario, and we did an MRI of the prostate. So MRI showed prostate is enlarged and near complete replacement of prostate parenchyma with hypointense and T2 hypertensive enhancing abscess involving both central as well as peripheral portions of the gland, showing restricted diffusion with the corresponding low IDC levels associated with mild periprostatic fat stranding. So eventually enter prostatic abscess with mild periprostatic fat stranding.
Sir, but why prostatic abscess is not picked by sonography?
So that was not a good sonography. It was done outside, sir. We suspected, therefore we have asked for this MRI. Definitely, it was not showing good images.
So roll up MRI in prostatic abscess.
Yeah. So how we are going to manage it now? So what are the different ways, Aditya?
So usually, sir, once the patient has formed prostatic abscess, sir, we can either drain it transurethral or parectally, sir. Preferably is transurethral drainage of the abscess, sir. So with the proper antibiotic cover, sir, we explain the patient in detail, sir, about the condition, and then we will plan for drainage of the abscess through a transurethral route, sir.
Transurethral or transrectal?
If preferably transurethral, sir.
And if you want to do transrectal, how will you do it?
So if on DRE we are able to palpate boggy prostate, sir, or truss guided we can do, sir.
Okay.
See, I think you must be very clear on your indications for transurethral resection, or you want to do aspiration of the prostate abscess. Today, I think many interventional radiologists have started doing a lot of aspiration of the prostatic abscess. And many times the results are quite satisfactory. In our time, the only treatment was TUR, and sometimes not as simple because abscesses may be deep and you have to keep on resecting without knowing where is the cavity. Today, things have changed. So I think you must be very clear what are the indications for aspiration of the abscess and which are the contraindications and where you will have to do transurethral resection to drain the prostatic abscess. Okay.
Exactly. If the abscesses are small and multiple, so you cannot aspirate, you cannot do resection. That is one scenario. Another scenario is abscess accessible through periurethral route. So accessibility can be judged by doing abdominal ultrasound, MRI, whatever investigation you want to do. If it is involving the transitional zone or zone nearest to the urethra, that can be easily accessed to the transurethral route. But if
and another is when you do PR, and if it is a very boggy, and if you think that it is a thin liquid compared to a thick pus, then you can attempt rectal aspiration. And if it is not possible to get it, then you do transurethral resection. Dr. Oza, anything on that you would like to comment?
I think that's fine. Also, I think if you had a suspicion of abscess, transabdominal sonography is not an appropriate investigation. It can miss abscesses. So, I mean, thus, I personally is not contraindicated. There are some limitations that you must know, but it is not contraindicated as I understand. But if you don't want to do truss, at least you must do MRI or CT scan. Remember, once you are in a clinical practice, I mean, I'm talking as a urologist, once tomorrow you are practicing outside, it is important for you to have a proper diagnosis. Now, sometime here you can take a chance, 10 days, 15 days. In a private setup, that may not work out. So if patient has responded, it's okay. But in doubt, I think it is appropriate to do appropriate investigation to come to proper diagnosis. I think that's where here probably because he responded, further investigations were not done. But if in doubt, you can certainly go ahead and do the further investigation to confirm whether it's an abscess or it's not an abscess. Your main fear is a rupture of abscess in a tissue or in area where it can create a fistula. Because that's the biggest problem, that sometime if it ruptures, say sometime in the rectum, sometime in the perineum, not very common, but it is seen, then it becomes a problem. That's where at timely interval, drainage of the abscess becomes an important thing. Am I
Therefore,
right,
we
Gaurang, on
suspected.
this?
Yes.
Absolutely, sir. This is what happened. We had a suboptimal sonography, and because we were suspecting that we are missing an abscess, we got an MRI done, and it was definitely bang on that there were abscesses, large abscesses.
So for students, yes, in exams, you don't want to doubt the investigations given to you. But nothing is wrong that if you find that the investigation is not appropriate to your liking, I don't think anybody can blame if you say that I would like to repeat the sonography, or nowadays there are people who do their own sonography. Remember, when patient comes to you, they are coming to a super specialist MCH urologist. So they expect a proper diagnosis and proper treatment. So whatever is necessary, don't hesitate in doing that if you're not happy with the given investigation. Because unfortunately, many times in urology, it's the investigation we are dependent on to decide our final treatment. So I think one of the messages that, be it CT scan, be it MRI, be it sonography, if you find that it is not up to the mark, now the examiner may say, that's okay. I don't think these are the findings. Then you are safe, that you have mentioned that though I had asked for an investigation, it is not given appropriate the way I wanted. So I think always keep that in mind, that if you want to repeat, nobody will blame you. At least the examiners will think that, well, you are strong on your suspicion and you want a definitive diagnosis before starting the treatment.
So there are two important things which we have learned today in this case, that never stop at one investigation. If you are doubting, please go ahead, either repeat the same investigation or do something else to prove your diagnosis so that you can give the right treatment. That is what Dr. Oza has told us. And the second most important thing is, never say that I may do this or I may do that. Means I may aspirate or I may do transurethral resection and drain the abscess. You must give your answer that in this particular case, what treatment you will give and why. So these are the two most important things you have learned in this case. So Hiren, what you had done?
So there were large abscesses when I went and discussed with the MRI with the radiologist. He said there are multiple septic abscesses and large abscesses and protruding inside, so in the urethra. So we decided to do TURP. Just show the video, Brijesh bhai.
Yes, sir.
Thick pus, multiple pockets, and like Umesh sir said, that we need to be very careful because these could be going deep down and we don't want to cause deep perforations. So just open the mouth of the abscesses uh, and being careful not to go maintain the plane. So there is another video showing that mouth of the abscess is nicely opened and we pulled it out.
So Santosh, what are the, when you do drainage of the abscess, what are the post-op complication you are expecting?
So the patient is already, there's formed abscess is there, so there is a possible septicemia, sir. be giving a higher antibiotic.
So one is a septicemia. Second is?
And if it is deep down, when we are doing the TUR, PURP, it may injure, I mean, as sir told, it may injure the rectum, and it can go down.
You have to be very careful about the sphincter.
Sphincter.
Patient can become incontinent.
Yes, sir.
Because this abscess may be extending distally. Third thing is, there is an abscess. Abscess means the chances of bleeding. You cannot stop it. No? The capillaries and the blood vessels.
Yes, sir. Inside, we are not addressing the inside
cavity.
if there is any capillary. So we should take care of, we should monitor the patient that there is a patient is having any hematuria post-operative.
Then fourth, post-operatively, there are chances that this abscess or the other material can obstruct the catheter.
It can obstruct and cause already patient. It can cause a retention. I mean, blockage of the catheter if it is there. Sir.
Yeah. Fine. Oza sir, you want to add anything?
No, I think that's very good. Also remember, sometime there may be a residual abscess, because if they are deep down, sometime it may not be, it sounds very easy. And when you see pus coming like this, it is very satisfying to see that on the table, I can tell you that. But sometime in the depth to reach becomes a little problematic. So it may happen sometime that there can be some residual pus which remains. However, once you have created a window, most of the time it will find its own way, and then subsequently even antibiotics may work well. So in post-op invasive, if you see some small cavities, it's not necessary that you have to resect again. But I think what happens nowadays, patients reads every line of the report once you come to the private setup. So it's important to tell patient that, well, we have created a window and we hope that all the pus will come out, but there may be some dead tissue or infected tissue which has not formed an abscess as yet. And if it forms a pus again, we may have to drain it again. Now, this communication saves you. Otherwise, patient may feel that you have not done a proper job, because there will be some tissue which is still sloughing and may form an abscess little later. That's why they need a follow-up, but it's always good to sound the patient, the relative, that whatever possible, we have created a window, we are giving a chance for pus to drain, but in future you'll need a follow-up, because once in a while it can form more pus and may need another procedure. So I think these are the few practical points once you are in practice.
It's a very important point, sir. We discussed it with the patient and we told him to follow up. And in fact, he has already come for the follow-up. He's doing well. And another practical point, because of this, what sir said, we did a pre-operative per rectal examination. And at the end of the resection, again, we did a rectal examination to see that whether that bogginess has disappeared. And it was quite satisfying that there was no more pockets of pus left.
Yes.
And on follow-up sonography, it's a good result.
Once in a while, when it becomes difficult that you are resecting, but you can't get a pus, it's
Yes,
not a bad idea to do intraoperative transrectal sonography. And under that control, you can find where exactly is the cavity, and just one cut in that proper region and the pus will drain out. Because, it can happen that you keep on resecting. And very interestingly, normally near Veru, if you see around 5 and 7 o'clock, and where the vessels also come, that's where sometime is the mouth of the abscess. And unless you open that place, the abscess may not drain. Now, again, as very rightly said, that's the area where you are near sphincter. So these are some points that you have to be careful, but in doubt, if possible, you can always get intraoperative transrectal sonography and identify where exactly is the cavity that will make you safe.
I think it's a very, very good and valid point. And actually, I will remember that next time.
All these are the rescue phenomena told by sir. But if you have a clear-cut idea about the pattern of abscesses and number of abscesses with preoperative investigation, that will decide the approach of the treatment. If
I
suppose
agree with you.
transurethral, perrectal, or aspiration with antibiotic, or no aspiration, only antibiotic. So these are
Absolutely.
the four options.
So
So if
good
it is
discussion with your
involving the
radiologist is
peripheral zone, so there is no use of doing a transurethral resection right up to that area.
correct.
It will definitely perforate the capsule and flare up the phenomenon. So better is the perrectal approach. If it is involving the transurethral, near to the transurethral area, whatever sir has done excellent job. Post-operatively, definitely you have to go ahead with clinical examination, that is perrectal examination, and ultrasound also for
Yes,
some
sir.
residual abscess. If that some abscess is not communicating with that particular abscess can be aspirated with ultrasound. If it is not getting resolved with antibiotic, and if patient is symptomatic. Otherwise, antibiotic, and as Oza sir says, it will definitely get resolved or drained via that open window.
Fine. Okay. So we go ahead with the last case, third case. We'll finish it in 15,
Sir,
20 minutes.
I have a doubt, sir. Can I ask, sir?
Yeah.
Sir, in the case of normal, not the abscess, in the case of prostatitis, sir, what is the role of catheterization, sir, in the sick patient with severe LUTS? So is it advisable to catheterize the patient, sir?
If the patient has a prostatitis and if he is clinically presented with severe voiding symptoms and significant post-void residue, clinically bladder full, you have to do a catheterization. If he is passing urine minimum post-void residue, antibiotic alpha blocker.
Okay, sir. Sir, what about a prostatic massage, sir? In the case of prostatitis, is it advisable, sir?
How it will work? I also don't know, but Walden Oza sir will throw light on that.
Once upon a time, that used to be the mode of treatment. At present, I don't think that we follow that pattern.
Yes,
because
no
end
role.
of the day, unless there is an opening, that massage will not drain anything. And partly that is one of the reasons why we give alpha blockers, that alpha blockers may relax and give a space. Because as you know, prostatic glands are complex glands. They are not straightforward. They are multiple branches and all. So that's where we hope that the alpha blocker helps in drainage of the secretion of the infected prostate. But I don't think that now we practice prostatic massage.
Okay, sir. Fine, sir. Because anyway, most of the patients won't be comfortable with it and they will be in
That's right.
severe pain. I just
It's
wanted to ask
painful.
this.
It's painful, and again, you don't know the outcome. I think other procedures work much better than a prostatic massage, be it antibiotics, alpha blockers, and as an require appropriate intervention by the appropriate technique.
Yes,
correct.
Yes. Thank you so much. Thank you so much.
Okay, so now we'll go to the last case.
A 58-year-old male patient came with difficulty in passing urine since 2 months and pain in right flank region since 1 month.
Okay, Santosh, fast. What are the possibilities?
Gaurang?
Yes, sir.
And everybody, thank you very, very much to allow me to be part of this discussion. I am just waiting for Dr. Oswal's telephone for our subspecialty meeting, so you have to excuse me. But
yes, sir.
Once again,
But
you
sir,
are doing a great
please
job.
join every Tuesday we are there. You can join in between, sir.
Sure.
Thank you, sir.
Thank you
sir.
so much. Thank you very much.
Thank you, sir. Thank you. Okay. So quickly, Santosh.
Sir, we will like to know from the patient elaboration of the difficulty in passing this LUTS symptoms, sir.
Okay.
And yes, sir, and he's also having the right flank pain. So we'll ask you about the right flank pain in elaboration, sir. And the patient is having any, yes, sir.
Okay.
Patient asymptomatic 2 months started developing difficulty in passing urine, increased frequency, hesitancy, and had funky score of 13/35.
Give
Pain
all
over right
the
flank.
history.
Yeah, pain over right flank region since 1 month. Pain was dull, diffuse time. Vaginal approximate increased intensity in 15 days associated with nausea, no specific aggravating factors, and was relieved on taking analgesics. No burning maturation, no hematuria, lituria, no previous instrumental catheterization, no history of vomiting or facial puffing, etc. He had no comorbidities, and family history was not significant. Rest sleep was disturbed because of lower urinary tract symptoms, bladder uh, activity was altered due to other symptoms. He was non-smoker, non-tubercular, no.
Yeah. So Rahul, he has got right flank, I mean the right lumbar region pain, and he has got lower urinary tract
Difficulties.
symptoms. So in considering these two things, what are the most probable diagnosis that comes into your mind?
Sir, most commonly, sir, by right flank pain associated with lower urinary tract symptoms, I would like to keep prostatic enlargement as a first differential diagnosis with median lobe enlargement, which is obstructing the right ureteric orifice.
How often you have seen this way?
Sir, or maybe due to the sir obstructive uropathy, sorry, bladder outlet obstruction, which can be presented as a pop-up mechanism for the right side, which
So
lead
either
to
it is a double pathology or it is a one
is a
pathology
one
which is
pathology.
giving rise to both the problem. Correct?
Sir, maybe
So double
yes, sir.
pathology is
Maybe possible, sir. There may be a stone at vesicoureteric junction, which can be lead to the lower urinary tract symptom associated with right line pain, which causing pain.
fine. So one is that you are saying that at the uretrovesical junction stone giving rise to these two problems. Second thing, it may be urolithiasis. Along with that, there may be an outlet obstruction. Correct. Third will
Yes,
be
sir. Sir,
it may
as
be a
per
CA prostate, which is
considering his age,
involving the right
it may
ureteric
get
orifice and giving rise to this pain.
yes.
Right? So either there are two pathology or there are one pathology which is giving rise to both the things. So now in this case, how you will go ahead? So what
Sir,
you are expecting in general examination and systemic examination to be very specific, and let's go ahead.
Sir, in general examination, sir, I would like to see there is any peripheral bilateral lower leg swelling will present, or sir, there is any sir, bilateral lower leg swelling present, puffiness of face. In sir, in local examination, I would like to see the left flank, sir. Is there any tenderness? There is any swelling present, or it is palpable, bimanually palpable or not? Then, sir, I would like to see the suprapubic any tenderness or distension is present, as well as external urethral external genital organ. I would like to see, sir, for any abnormality.
Okay, Brijesh,
with
go ahead.
per rectal examination to look for the prostate.
Fine, Brijesh, go ahead. Just show him everything.
The general examination was normal. No any edema or no lymphadenopathy or anything. Pulse rate, blood pressure, everything was normal. Local examination, everything was normal. No any hernia.
Go ahead. Go ahead.
Grade 2 prostatic enlargement could be found on rectal examination. Prostate was forming consistent smooth surface and no tender medial surface pathology. But abdominal examination was also normal. No any abdominal lump or
So it was
mass.
everything was
No
normal,
any
correct?
tenderness clinically.
So only finding was
Yes,
that per rectally there was a grade 2 prostate. Fine. So Santosh, now what you want to do now?
Sir, I would like to investigate the patient with a routine investigation, sir, like CBP, CBP, RFP, CU, and urine, this ultrasonography and Euroflow, sir.
Okay, Bridges, show them.
WBC count was 12,000. HbA1c was 6.6. PSA also we did, it was 3.2. Urine routine had pustules of 15 to 25 high power red blood cells per occasional. CS had Pseudomonas aeruginosa, which was sensitive to phosphomycin. And uroflowmetry.
Okay, show them ultrasonography also.
The ultrasonography revealed a large right-sided calculi, which was 34 mm, which was occupying the renal pelvis. And there is no evidence of obstructive uropathy on the right side. 14 medical differentiation was normal. Left kidney was normal, and prostate was 64 grams and enlarged.
And post-void was 90 ml.
Post-void was not.
Yeah, so Aditya, now next what? What you want?
So for the
See, Aditya, this
calculus part,
patient has,
yes.
listen, this patient has infection. This patient has got, now you know that he has got a stone disease. He has got a residual of 90 ml and he has got an enlarged prostate. So how we are going to manage this patient?
So primarily, we have to start the patient on antibiotics. So culture-specific antibiotics would be started for this patient.
So which antibiotic will start?
It was sensitive to phosphomycin, sir. So like start the patient on phosphomycin 3 gram sachet, sir. And along with that, start the patient on an alpha blocker, sir.
Okay, fine.
And then see the symptom. Since the prostate size is 64 grams, I would also like to add 5-alpha reductase inhibitors on alpha blocker.
Okay. Next.
And I would like to explain to the patient that the patient has a large stone, sir, in the renal pelvis, which would require further treatment, sir. So for that, an NCCT KUB would be required during the evaluation of stone, sir.
Fine. Bridges, show them. We unfortunately we don't have the plates. Okay, but we have done the X-ray and we have got
the report. This is the X-ray. We can clearly see a right-sided staghorn calculus. And CT report. CT report was suggestive of a large staghorn calculus of 6.6 by 2.1 by 3.8 centimeter, involving the right renal pair extending into the upper interpolar and lower poles of calyx. Prompt excretion of the contrast medium was seen in the right kidney, and renal parenchyma shows uniform enlargement. Mild urothelial thickening was seen on the right side of renal pelvis and upper ureter. The diffuse perinephric and upper ureteric fat staining was noted. Left kidney was normal. Prostate appeared to be enlarged in size, and there was no focal lesion. Rest urinary bladder was also normal.
fine. Santosh, now what you want to do?
Patient is having two pathologies, sir. One is a staghorn calculus, and one more is moderate prostatomegaly with moderate symptoms, sir. So after treating the patient's infection, he was having infective urine, so we'll give an antibiotics, culture-sensitive antibiotics to him to treat the infection. After that, first we.
So infection is because of residual urine or it is because of the stone?
It is staghorn calculus, so it can be due to stone, sir.
Then why he doesn't have fever, chills, rigors? Aditya.
So it is a long-standing non-obstructing stone, sir.
Sir,
okay. Yeah, go ahead.
So it is a non-obstructing,
Non-obstructing.
non-standing stone, sir. And the patient has a symptom which is an acute symptom, sir. So it is, and the patient, however, has diffuse abdominal pain on the right flank, sir.
Listen,
So we can,
listen, he has got a pain in the right lumbar region, correct? The aching,
Yes.
whatever it is. Fine?
Yes.
So that pain is because of what?
Because of the
Stretching of the
infection secondary to
capsule.
stone, sir.
So that means there is some obstruction, no?
Yes, sir. Stretching of the capsule, that staghorn calculus may obstruct the kidney, so that lead to the
Even
flank
though
pain.
there is no obvious hydronephrosis,
Hydronephrosis.
there is definitely, correct?
Yes.
Yes.
Yeah. Fine. So now what you want to do?
So primarily for his stone, sir, I would like to plan a
So you want to
degestion on
do
the
stone
right
first,
side.
or you want to treat prostate medically and you want to do stone, or you want to do prostate surgically and then go ahead?
Primarily medical management for prostate, sir. See how his symptoms improve. And in the meantime, also plan for a degestion on the right side, sir. Since the patient has presented with infective etiology. Once the infection is settled and we assess how
You
his
think that
prostate is.
digestant in this case will help? Which calyx will put it?
Rarely it will help, sir.
So my question is whether you will do both the things or you want to do only one thing, or if you want to do both the thing, which you will treat first?
Sir, as IPSS symptom severity, this patient comes in moderate severe grade. We can try with sir, alpha blocker plus 5 alpha reductase inhibitor, and we can then go ahead with the stone management, sir. As it will, if it will relieve the relief the patient.
Okay. Dr. Maheshwari, can you throw some light on this? Or Dr. Gite, sir, you can also tell how they should answer in exam.
The patient presentation, clinical presentation has the right loin pain and lower tract symptoms. So post-acute residue is near about 50%. So we will start with oral antibiotic and alpha blocker, 5 alpha reductase initially. We will reassess the things in terms of symptoms, post-acute residue, and if required, uroflowmetry. If he is improving for the lower tract with the medical treatment or conservative treatment, then we will continue the same treatment and go ahead with the treatment for renal stone after that. As far as digestant is concerned, whenever there is no hydronephrosis, the placing the digestant may not be help, and on the contrary, it may introduce the infection inside the system. Because on CT scan as well as the sonography, there is no any internal echoes inside, or there is no any hydronephrosis. So de-obstruction as a primary treatment beforehand, before treating the lower tract is not a good idea. Upper tract I will keep behind, and I will go ahead with initial treatment in terms of medical treatment for the lower tract. And if lower tract settles down, then I will go ahead with whatever PCNL, multi-track PCNL, ECIRS, or open surgery, whatever the way I want to defend in exam.
You understood what sir is trying to tell you? It is like that you have got, listen, you have got both the right also sided stone and also the left side stone. How you are going to manage, how you are going to decide which side you are going to operate first?
Sir,
so number one,
better
correct.
side.
So number one is which one is a symptomatic.
Yes.
Correct. Second is which is more obstructed. Then third will be which is better functioning. Like that. So now in this case, you have to decide that which symptoms are bothersome, number one. Second thing is, if the right kidney is really hydronephrotic, and if you think that if you don't tackle that first, then you are going to lose that kidney, then you have to treat that stone first. If patient is going into retention, if he's not improving with the medical line of treatment, is worsening, then you have to treat prostate first. Okay. So as Dr. Gite said, treat the infection. Once the infection comes under control, along with alpha blocker, or you can add any other medicine, 5-alpha reductase or whatever it is, keep him under observation and see if once he improves and the infection is under control, now you decide whether you want to go ahead with only PCNL, or first you want to do TURP because his flow is not improved. He has got residual urine, he has got probably pus inside the bladder. So first you manage that and then you do PCNL. But if he improves, then you can go ahead, first do the PCNL, keep him under observation. If he deteriorates, then do TURP. Otherwise, you can manage him medically. So in this case, patient had improved. We decided to do PCNL. Unfortunately, we don't have film, video, but these patients' right ureteric orifice we could not find out. So we did a TURP first, and then later stage, we did PCNL.
Yes, sir.
Yeah, any other questions?
I think 3 very good cases we have discussed with different types of scenarios. Prostate with hernia, prostatitis with abscess, and stone with prostate. That's very good cases, I think. So if you all have any questions, even next time we can discuss. If there are any doubts or comments, we can take it.
Okay.
Okay, sir. Good night, Gite sir. Good night, Gaurang sir. Good night, Pankaj sir.
Good night. Good night, everyone.
Thank you,
Good
sir.
night, everybody.
Thank you. Thank you.
Well done,
Good
all
night.
those who participated. Thank you, Paras. Thank you, Swastik. Thank you, Brijesh.
Thank you.
Good night.
Thank you, sir.
Good night.
Good night.
Bye.
Sir, please end the session.